Good morning, respected Dr. M.N. Swankar sir, respected Dr. Sudhir Sardeva sir, all the respected faculty and dear residents. I welcome all of you in today's CCR. Today's CCR is going to be presented by Department of Medicine, Unit 3. Today's CCR is about a patient who came to us with some common complaints, and on workup it turned out to be a rare disease. Now I invite Dr. Vaishali, our third year PG resident, to present the case.
Thank you, sir. A very good to everyone. I shall be proceeding with the case. We had a middle-aged woman with shortness of breath. A 47-year-old woman was admitted to the hospital with complaints of lump in upper left abdomen since 3 years, generalized weakness and fatigue since 3 months, and shortness of breath since 7 days. History of present illness. Patient was apparently alright 3 years back when she noticed a lump in her upper left abdomen which kept on gradually increasing in size. She also had generalized weakness and fatigue since 3 months, which was progressive. She was able to do her household work without any breaks initially. However, now she had to take rests in between to finish her course. She also had shortness of breath since the last 7 days, which was progressive. She has grade 1 dyspnea for the first 4 days, which progressed to grade 2. She did not have any history of orthopnea, paroxysmal nocturnal dyspnea, chest pain, palpitations, cough and fever. Coming to the past history, the patient was a known case of hypothyroidism since 18 years on tablet thyroxine. She also had a history of low hemoglobin since 5 years, for which she was taking supplements, iron, folic acid and a multivitamin. There was no history of any other comorbidity in the patient. So, coming to the negative history, there is no history of bleeding from any site or black stools. There is no history of fever with chills, loss of appetite, weight loss, jaundice. There is no history of blood transfusions, no history of bony pains or any joint pains, no history of cold intolerance, menstrual irregularities, constipation, weight gain. There is no history of hair loss, oral ulcers or any skin rashes. Coming to the family history, there is no similar history in family and no other significant family history. Personal history, she took a mixed diet. Appetite, bowel bladder and sleep were in normal limits. Menstrual and obstetric history, her age of menarche was 12 years. Her menses used to last for 4 to 5 days in a 28 to 30 days cycle, normal regular flow. She attained menopause at the age of 46 years. Para 3, living 3, abortion 1. She has 2 daughters, one is 24 years old, another one is 22 years old, and a younger son who is 18 years old. There is history of 1 abortion during first trimester, 21 years back. Coming to the general physical examination, the patient was moderately built, fairly nourished, conscious, oriented, pallor was present, there was no cyanosis, icterus, clubbing and lymphadenopathy. Day 1 of admission, vitals. BP was 110 by 70 mmHg taken in left arm, supine position, heart rate 110 per minute, regular, high volume, normal character, no radial or radiofemoral delay. Temperature 98.4 degree Fahrenheit, oral. Saturation 99% at room air. Respiratory rate was 18 per minute, thoracoabdominal. So character, so we have different characters for the ones. Sir, pulses, powers, retarders, paradoxes, Coming to the per abdomen examination, on inspection the shape of abdomen was distended, otherwise it was unremarkable. Lightus inverted and centrally placed, normal abdominal movements, no sinus scar or swelling. Coming to palpation, liver was 6 cm palpable below right costal margin in right mid-clavicular line, soft, non-tender, smooth surface with rounded borders. Liver span was 17 cm. Coming to the spleen was 8 cm palpable below left costal margin, firm, non-tender and its notch was palpable. Percussion and auscultation did not reveal any remarkable findings. Coming to the systemic examination, respiratory examination, bilateral air entry was present and there were no added sounds. CNS also was within normal limits. CVS showed a loud S1 with systolic murmur at base of heart. S2 was normal. Coming to the summary, a 47-year-old female, known case of hypothyroidism since 18 years, presented with complaints of lump abdomen, fatigue and shortness of breath. There is a past history of anemia since last 5 years. She is taking iron, folic acid and multivitamins. Pallor and hepatosplenomegaly were present. Now I would like to ask the house that what is their differential diagnosis for this patient. So differential diagnosis, the first one infective, malaria, HIV, tuberculosis or leishmaniasis. Although the patient did not have any history of fever, but still since in some areas malaria can present with splenomegaly, that is chronic malaria can present. So HIV, tuberculosis, leishmaniasis also can present like this. Coming to the hematological diseases, CML, myelofibrosis, lymphoma, leukemia, hemolytic anemia and hemoglobinopathies. Autoimmune, as already mentioned, that she had one history of abortion, and since she is a female, the sex already being more predominant in autoimmune diseases, so it was kept as a possibility. Coming to the vascular diseases, portal hypertension, although a bit lower on the chart. Intrahepatic may be cirrhosis or due to NCPF, extrahepatic may be HPV. Coming to infiltrate, sir, NCPF is non-cirrhotic portal fibrosis, extrahepatic is extrahepatic portal vein obstruction. Sir, when the first order vessels of portal vein are thrombosed, we call it EHPV. When the third order, that is inside the liver, are thrombosed, we call it NCPF. Coming to miscellaneous, it could be due to any nutritional deficiencies. Uncontrolled hypothyroidism in some cases can lead to anemia and then extramedullary hematopoiesis. Lysosomal storage disorders kept at the last because the age is not favoring. So the patient came with these investigations, that is they were done from outside. Her hemoglobin was 4.4 gram per deciliter. She had severe thrombocytopenia, platelets were 8,000 and she had a TSH of 4 with an ESR of 48. It is to be noted that the MCV was within normal limits, that is 84 femoliter. Serum creat was also normal. So relevant investigations were sent before transfusing any form of blood products. 1 unit of PRBC and 6 units of RTP were transfused to the patient. So now I would like to ask the house that what further investigations in this patient you would like to order. So coming to the investigations, hemoglobin was 5 gram per deciliter, platelets was 16,000 and ESR was 42. MCV came out to be 96.9 femoliter and LDH was 240 units per liter, retic count was 2.5%. PBF, RBCs were predominantly normocytic normochromic. There were 35 nucleated RBCs per 100 WBCs seen. TLC was within normal limits, however DLC showed myeloid left shift. There were metamyelocytes and myelocytes seen. Platelets were reduced on smear. There was no parasite seen and the PBF gave an impression of leukoerythroblastic blood reaction. Coming to the LFT, OT, PT, bilirubin, albumin, PTNR, all were within normal limits. RBS was 90 mg per deciliter. Coming to RFT and serum electrolytes, RFT was within normal limits and serum electrolyte were also within normal limits. The urine routine also did not reveal any abnormalities. Coming to the iron profile, serum iron was within normal limits, 120 microgram. TIBC and ferritin were also normal. Vitamin B12 was normal. HIV, HPS, AG, anti-HCG were negative. Stool routine did not reveal any ova or cyst, no occurred blood. Dengue, NS1, IgM were negative, ANA was also negative. TSH was 3.2 microinternational units per ml. ECG revealed sinus tachycardia, otherwise a normal ECG. Coming to the ultrasonography whole abdomen, liver was 16 centimeters with a normal ecotexture. Spleen was 17 centimeters, moderately enlarged. Splenic vein diameter was 9 mm. Portal vein diameter 10 mm and there was no evidence of any thrombosis and collaterals. This was the chest X-ray. The lung fields were normal. Now I would like to ask the House what would be your differential diagnosis based on these investigations.
And what further investigations you want? One key investigation, one of the boys or girls point out quickly. Next, most important investigation would be what? Very easy question. Excellent. Next, diagnosis clinching investigation would be a bone marrow aspiration and biopsy. Okay?
So we ruled out the infective causes. Malaria was not seen on the PBF. HIV was ruled out on serology. X-ray ruled out tuberculosis, X-ray and history both. Leishmania was also not seen on the PBF. Coming to autoimmune, ANA was negative, so it was ruled out. Vascular, the liver did not show any changes. No portal vein diameter was normal, so portal hypertension being ruled out. Infiltrative sarcoidosis was ruled out on the basis of X-ray. Miscellaneous nutritional deficiencies, uncontrolled hypothyroidism and lysosomal storage disorders was also ruled out on the basis of investigations. Since the TNC was normal, CML was also ruled out in hematological. Now I would like to ask the House that what findings do you see in this X-ray?
One input is that this is an overexposed X-ray.
Yes, sir.
Yeah?
Yes, sir.
I think that's a first possibility which you should consider. And obviously this is a digital X-ray, so that remains important. Anything else? Any other abnormalities which hits you? Yes. Excellent. The heart and the lungs are okay, but the bone density, if it is a normal exposure, appears to be diffusely increased. Very good observation. Okay.
So now I would like to invite Dr. Ashna to explain the X-ray.
Thank you, ma'am. Good morning. I'll be describing the plain radiograph findings. So here we have a chest diagram, posterior anterior view showing a generalized increase in the bone density of all the visualized bones as mentioned. Being a posterior anterior film, the anterior ends of the ribs are quite prominent and the bilateral scapulae are also very dense, suggestive of an increased bone density. Had it just been an overexposure, we would not have been able to see the intervertebral disc spaces. The soft tissue shadows would also have been much more brighter, which is not the case. The lung fields are clear, the CP angle is also clear, hilar shadows normal, and the CT ratio is also normal. For a chest film like this, the differentials could be fluorosis, which is common, and also we see a diffuse increase, a very homogeneous increase also in fluorosis. Other common causes could be metastasis, most commonly from prostate and breast cancers, sickle cell disease, myelofibrosis, renal osteodystrophy, osteopetrosis, Paget's, and hypoparathyroidism. This could all be the differentials. I would like to call back Dr. Vishali to continue.
Now, proceeding further, the question was whether the bicytopenia and chest X-ray findings were the part and parcel of the same disease or two different diseases. Keeping in mind the radiology findings along with bicytopenia, hematology reference was taken. I would now like to invite Dr. Naveen Gupta sir.
Thank you, Dr. Vishali. So we had a case, so if we just look at the presentation, we had anemia, we had splenomegaly, splenomegaly being of a slightly longer duration, roughly 3 years. So for the benefit of the residents, I will just go through like a step-by-step approach. If you encounter a case of anemia, like how do you think? The most obvious thing that you think initially is there any blood loss? So based on the history in this patient, yes, we can say there is no such evidence of blood loss. We can, if we had, say, portal hypertension or any GI bleed, a patient would have a history of hematemesis, maybe black colored stools. The patient has been menopausal, so no history of any menstrual blood loss. In cases of severe blood loss, the reticulocyte count initially would be high, later on it would drop to very low because the iron would get depleted with chronic blood loss. The iron studies in this patient were also normal. So we can safely say that blood loss is definitely not part of the illness here. Second being whether is there any hemolysis or any hemoglobinopathies. So in severe hemolysis, we can get a leukoerythroblastic picture where we can get nucleated RBCs and a left shift. In hemoglobinopathies also, if they are untransfused and are having severe anemia, we can get a leukoerythroblastic picture. But with hemoglobinopathies, usually the picture is a microcytic hypochromic one, the MCV would be quite low. In our patient, the MCV was normal. Also with hemolysis, we would expect an elevated reticulocyte count, elevated LDH and an elevated indirect bilirubin, which was not the case in this patient. So despite having a large spleen with anemia, it's almost reflexly, we think that it could be an autoimmune hemolysis, but there is no such feature of autoimmune hemolysis here. So we don't have to go down that path for the workup. Last comes whether this is a failure of the marrow. So the history would support it. There is a long-standing history of anemia. The patient had been taking hematinics for 4 to 5 years and probably was not responding, presented with a hemoglobin of 4. On examination, the patient had a significant hepatosplenomegaly. On the PBF, we had a leukoerythroblastic picture which can be seen in marrow infiltrative disorders, which can also be seen in disorders where you got like a marrow failure leading to extramedullary hematopoiesis. The reticulocyte count and the LDH would be low to normal in such cases. So all the findings are pointing towards something going wrong with the marrow. So you've got a chronic disorder. It has been associated with thrombocytopenia. So it's not just pure anemia, it's anemia with very severe thrombocytopenia, severe enough to require transfusions at the time of admission, with hepatosplenomegaly, leukoerythroblastic PBF, and a low retic and a normal LDH. So we can say that there is something infiltrating the marrow, there is something inside the marrow which is causing this thing. So infiltrative disorders have a known name, it's called a myelothysic disorders. So you can have a variety of things infiltrating the marrow which can present with such a picture. Myelofibrosis being one, either primary myelofibrosis with a chronic myeloproliferative neoplasm, or because of secondary causes of myelofibrosis, where you can have hyperparathyroidism as one of the causes. Infections and autoimmune disorders can lead to secondary myelofibrosis. Granulomatous infiltrations are also commonly seen. This is seen in cases of disseminated tuberculosis. Sarcoidosis is also sometimes associated with granulomas in the marrow. Histoplasmosis is also something that we see once in a while. Lymphomatous infiltration in the marrow can also lead to such a picture. In this patient, since we have hepatosplenomegaly and anemia for a long duration, it could be a low-grade lymphoma. Metastatic solid tumors can also lead to a leukoerythroblastic picture, although we don't have any such history of a primary. Also, a metastatic solid tumor would not drag on for 3 to 5 years before getting diagnosed. So it's not relevant in this case, but yes, myelothysic anemia can be there. And last comes osteosclerosis. This can be, in clinical practice, we routinely see it with long-standing CKD leading to renal osteodystrophy and dense fibrosis and leading to subsequent sclerosis in the marrow. And in severe cases of myelofibrosis, also sclerosis can develop. So, based on these findings and the X-ray finding is also one of the hints. So, bone marrow examination is expected to reveal the cause of the anemia and splenomegaly in this case. So, over to Dr. Vishnu.
Dr. Naveen, what is the status of direct home test in this case?
So we have not done a direct Coombs test in this case, but we are also not suspecting autoimmune hemolysis, and LDH and indirect bilirubin being normal. So that was not considered.
In the exam as well as in clinical practice, all patients with anemia, all patients with anemia must have stool for occult blood on 3 consecutive days, and even if there is no history of hematemesis, melena or hematochezia, patients can lose blood over a long period of time with no obvious GI bleed and come with very low hemoglobin. All patients must have stool routine examination for worms. We ourselves have operated on a patient with a diagnosis of occult GI bleed, did not find anything, and final diagnosis was hookworm infestation.
Coming to the summary of the case, a 70 or 47-year-old female known case of hypothyroidism with history of anemia. Examination revealed pallor and hepatosplenomegaly. Blood indices showed decreased hemoglobin and platelets. PBF suggested of leukoerythroblastic reaction, and chest X-ray showed a generalized increase in bone density. So bone marrow aspiration and biopsy was done. Now I would like to invite Dr. Shikha Goyal to take the case further.
As Dr. Vaishali has already told, the PBF examination of the patient was done and it revealed the leukoerythroblastic reaction, which is characterized by the NRBCs, erythroid precursors, and myelocytes and metamyelocytes in the peripheral blood smear. The causes of leukoerythroblastic reaction can be infectious disease, biliary tuberculosis, cancer metastatic to the bone marrow like carcinomas of lung, breast, prostate, hematological malignancies like hematological disorders like myelofibrosis, severe hemolysis, lymphoma, myeloma, and storage disorders. Basically, the cause of leukoerythroblastic reaction can be two things. Firstly, there can be altered marrow-blood barrier, which can be due to the which is caused by the disruption of the marrow sinusoids, by the bone marrow infiltrative disorders, non-neoplastic conditions like granulomas or storage disorders, or non-infiltrative marrow fibrosis, which can be caused as a result of radiation therapy. And secondly, extramedullary hematopoiesis can also be caused due to compensatory response of the marrow fibrosis and infiltration, and secondly by the bone marrow stress caused by the severe hemolytic anemias. So bone marrow aspiration of the patient was done, and it was a dry tap. Dry tap why? Because it didn't reveal any marrow particles, and bone marrow imprints also didn't reveal anything. So we called Dr. Naveen, and he told us that it was a very bony, stony hard bone. So we didn't get any marrow. Then the bone marrow biopsy of the patient came. So this is a normal bone marrow. Here we can see the trabeculae and the marrow filled with the hematopoietic elements. And this is the marrow finding of the patient, which revealed only the thickened bony trabeculae, intramedullary osteoid, and hematopoietic elements was seen. So a diagnosis of osteosclerosis was given. Over to you, Dr.
Coming to the final case summary, we had a 47-year-old female, known case of hypothyroidism with history of anemia, who presented with complaints of lump abdomen, fatigue and shortness of breath. Examination revealed pallor and hepatosplenomegaly. Investigations in blood indices revealed decreased hemoglobin and platelets. PBF was suggestive of leukoerythroblastic reaction. Chest X-ray revealed generalized increase in bone density and cardiomegaly. Bone marrow biopsy showed thickened bony trabeculae with diminished bone marrow cavity and intramedullary osteoid tissue and hemorrhage. So to rule out whether the osteosclerosis was generalized or localized, we went for a PET scan. And the PET scan revealed non-FPG avid diffuse sclerosis of entire visualized skeleton. Now, with osteosclerosis in picture, we try to review the literature to look for the various causes for causing osteosclerosis, which were broadly divided into acquired and hereditary. Causes of acquired osteosclerosis include fluorosis, metastasis due to carcinoma breast or prostate, Paget's, hypervitaminosis D, hyperparathyroidism, Schnitzler syndrome, mastocytosis. Fluorosis. The patient was from an affluent family consuming RO water, and changes in dentition are seen prior to the changes in skeleton in a fluorosis patient. On the right hand side we have a picture of mild and severe fluorosis patient, and on the left hand side we have the photo of our patient's teeth. So fluorosis was ruled out. Osteogenic bone metastasis caused by CA breast. There was no lump in the breast, there was no history of bony pains, so ruled out. Paget's disease is mostly seen in elderly age. It is rare below 55. Bones are seen in different stages of formation, whereas in our patient we just had the osteoblastic phase, so ruled out. Osteosclerosing type of chronic osteomyelitis. There was no history of fever or bone pains. There was no history of any discharging sinuses, ruling out osteomyelitis. Hypervitaminosis D. The vitamin D level was normal in our patient, 60 nanogram per deciliter, ruled out. Hyperparathyroidism. Parathyroid hormone level was 42 picogram per deciliter. Calcium was 8.6. There was no history of any renal disease in our patient, therefore ruling it out as well. Schnitzler syndrome, there was no history of urticaria, bone pain, joint pain, fever, so it was ruled out as well. Mastocytosis, there were no skin lesions, no history of anaphylaxis. Bone marrow also did not reveal any mast cells, so ruled out. So now after ruling out all the causes of acquired osteosclerosis, our focus shifted towards the hereditary causes. Reference was taken from Department of Medical Genetics, advice samples were sent. Since the report takes time to come, so we try to look into the causes of hereditary osteosclerosis, which include infantile, Buschke-Ollendorff syndrome, autosomal dominant osteopetrosis, and a few other names. I would be rushing through them. Infantile osteopetrosis, seen in infants, so ruled out in our case. Buschke-Ollendorff syndrome, found in people less than 20 years of age, younger, so ruled out in our patient. Autosomal dominant osteopetrosis is a benign type of osteopetrosis. These patients survive into adulthood, and this could be a possibility in our case. Osteopetrosis acroosteolytica, also seen in children or infants. They have wormy bones and other abnormalities, ruled out in our case. Osteopathia striata with cranial sclerosis, also ruled out in our case. Camurati-Engelmann syndrome, seen in childhood. Therefore, there are very thick bones, and this also is ruled out in our case. So I would like to invite Dr. Rekha ma'am to now.
Good morning, everyone. So in today's case, all of the acquired causes of osteosclerosis were ruled out, and even summarized the hereditary causes of osteosclerosis, and really they reach at a conclusion. So in this case, we advise the whole exome sequencing of the patient, because these are basically single gene disorders which cause osteosclerosis. So in whole exome sequencing, they do sequencing of all oral exomes. And in this whole exome sequencing, they found one mutation into the CLCN7 gene, and this mutation was found to be pathogenic. It means this mutation was previously reported in patients with autosomal dominant osteopetrosis. So here, by this gene mutation, we were clear that our patient was having autosomal dominant osteopetrosis, and really it was a hard work by the team, and they really reached at the conclusion without a gene diagnosis that it may be osteopetrosis. And when we looked upon the family, in this family, many were, I think, asymptomatic individuals are there in the family, because the patient who is presented to us, this lady, in second generation 2 number, a female present to us with anemia and hepatosplenomegaly, and she had osteosclerosis in X-ray, and no one other persons were symptomatic in her family. But when my brother came out for the taking care of that lady, then our resident did X-ray and CBC of that brother. Then brother was also having osteosclerosis in X-ray. Similar findings were there. So in autosomal dominant osteopetrosis, it is many individuals are asymptomatic in family. They even don't develop bone marrow disease. So there may be, because it is an autosomal dominant disorder, and 2 brother and sisters are affected. So one of the parent most likely affected, but clinically asymptomatic, so we don't know their status. So it is a typical, and as she has 3 offspring, 2 female and 1 male, so 50% time she will give this gene to her offsprings also. So they may be affected with the disorder, but it will be revealed on X-rays and testing of the child, because many times they may be asymptomatic. So next, I would invite.
So the final diagnosis came out to be autosomal dominant osteopetrosis type 2, that is Albert-Schonberg disease. 1 month after the discharge, the patient was doing well. Her hemoglobin was 8.6 and platelets were 52,000 on follow-up. Now to throw some light on this disease, I would like to invite Dr. Krunal.
Thank you, Dr. Vaishali. Good morning, everyone. Today I am going to throw some light on Albert-Schonberg disease. This disease comes under the classification of osteopetrosis, often called the marble bone diseases. It is a group of disorder caused by severe impairment of osteoclast-mediated bone resorption. It is divided into 3 types: malignant or infantile, which is autosomal recessive 1; intermediate, which is autosomal recessive 1; and benign, which is autosomal dominant 1. It is further divided into 2 types, type 1 and type 2. Type 1 autosomal dominant, here pronounced osteosclerosis of cranial wall is seen, leading to the cranial nerve compression, further causing deafness, blindness and cranial nerve palsies. And type 2 autosomal dominant, here sandwich vertebra or rugged spine is seen due to end-plate thickening, and bone-in-bone appearance, that is endobone appearance, is seen due to ingrowth of bone within the medullary cavity. So this is our case, type 2 autosomal dominant benign osteopetrosis, also known as Albert-Schonberg disease, named after the German radiologist Heinrich Albert Schonberg. Its prevalence is 1 in 1 lakh to 1 in 5 lakh, and due to the mutation of CLCN, that is chloride channel gene, it is less severe than the autosomal recessive variant, because most patients survive into adulthood. And here bone appear more denser, and due to the alteration of bone's internal architecture, bone gets weaker and more brittle. The clinical features due to the failure in skeletal remodeling, extramedullary hematopoiesis is seen, leading to splenomegaly, hypersplenism and pancytopenia. A patient can come with shortness of breath and fatigue due to the anemia, and it's not always a benign cause. Fractures may be accompanied along with loss of vision and deafness. Here serum calcium, parathyroid hormone and 125-dihydroxyvitamin D can come normal. Biochemical markers are CPK, BB and acid phosphatase. A radiograph usually shows the generalized increase in symmetry of the cortical and trabecular bone, and the gold standard one is the genetic testing. The treatment is only symptomatic one, that is orthopedic management for fractures. Patient is advised to avoid strenuous exercise to avoid fractures, blood transfusions when needed, and surgical intervention for cranial nerve compression if any. Interferon gamma-1b and methylprednisolone, the studies are going on, but effectiveness are limited for these two drugs. Now I would like to call Dr. Shikha for reviewing the literature.
Good morning, everyone. We have researched the literature thoroughly and came to the conclusion that most of the cases are from childhood, which are diagnosed in childhood, and presented with complaints of bone complaints, and only few cases were diagnosed in adulthood, which complaints of bone pain and backache. Our case is unique in this scenario, that our case presented with anemia and thrombocytopenia, which is the feature of bone marrow failure. So, in no other cases was found in literature of adulthood on the basis of these features. Now I am presenting some case report. The first case report is from New England Journal of Medicine, autosomal dominant osteopetrosis, in which the 38-year-old woman presented with a history of 2 months history of progressive back pain. In the second case report, the clinical and radiological findings of autosomal dominant osteopetrosis type 2. In this case report, the patient presented with chief complaints of deposits on teeth from last 6 to 7 months. And the next case report was from World Journal of Clinical Cases, Clinical and Genetic Diagnosis of Autosomal Dominant Osteopetrosis type 2 in a Chinese family. In this case report, a 53-year-old woman was presented with complaints of limb joint pain for 11 months.
So the take-home message for today's case is Albert-Schoenberg disease is an incurable at present. With systematic approach, multidisciplinary collaboration, and with the ease of availability of genetic analysis, even the rarest of the diseases can be diagnosed. And genetic analysis of the offsprings can help for the early detection of disease symptoms. As these patients might require repeated blood transfusions, iron chelate should be used at the right time. As we are working in a tertiary care hospital, it is our duty and responsibility to not only help the patient to get rid of the symptoms, but also to reach to the diagnosis. Whenever these kind of patients goes elsewhere, it not only reflects the status of the institute, the level of the institute, but also the work we are doing in the institute. And with the available infrastructure, with the presence of all the departments and the highly learned faculty, it is not impossible. So the great things are not done by the one person, they are done by a team of people. So we believe in a teamwork here. And we are thankful to our hospital management, Department of Hematology, Pathology, Genetics and Radiology, to the CCR Review Committee for the excellent work, patient and our family members, and to the Department of General Medicine. Thank you.